it's quite a limited time to cover quite a complex area. So I'm going to touch on some of the areas where I think we've learned lessons in our efforts to ablate patients with atrial arrhythmias and how those are relevant to cardiac surgery and how actually an integrated approach will really benefit our patients, I feel. This is the reason that atrial fibrillation has excited so much interest. In contrast to ischemic heart disease, it's increasing, not declining, as our population ages. So this is why there's so much investment in terms of time, research activity, and commercial interest in the disease. It's a very heterogeneous condition, and I think it's important to recognize that in different patient groups, you've got really different factors. And a sort of general concept in younger patients with normal hearts, the lone AF patients we're discussing today, the main factor are the triggers and drivers, which seem to come mainly from the pulmonary veins. There is evidence that the pulmonary veins share, or the tissue within the pulmonary veins shares embryological characteristics with pacemaker cells, with sinoatrial and AV nodal cells, explaining why there's this increased automatic activity there. We know the autonomic nervous system plays quite a big part in that. We're now aware of the impact of vagal ganglia. The renin-angiotensin system also has an impact as patients sort of progress from paroxysmal, and there does seem to be a progression towards the persistent form in many patients. There's a concept of electrical remodeling, that the more time you spend in AF, the refractory periods of the atrium change, there's more fibrosis develops, you get cell death, and you develop then substrate changes, patchy fibrosis, which sets up the substrate for re-entry and multiple re-entrant circuits. And this is where you have to start doing linear ablations. But if we focus on treating patients at an earlier stage, I would agree with what Manuel said. The key really is achieving pulmonary vein isolation, and that's where we can sometimes be successful, but I think we need some help. I don't want to spend a long time with this sort of slide because this is what causes my interventional cardiology colleagues' eyes to glaze over, but I'm crediting you guys with a bit more intelligence than them. This is just some intracardiac electrograms. This is an atrial signal and then a ventricular signal in the coronary sinus, left atrial, left ventricular. But then you get and you see that corresponds with a P wave on the surface electrogram and the QRS. It's a different speed than you normally see it. Then there's an ectopic beat earliest in this pulmonary vein. There's an ablation catheter around the origin of the right superior pulmonary vein. So you get a sinus beat and an atrial ectopic coming from the pulmonary vein, sinus beat, atrial ectopic, and after the third beat, sinus beat, this ectopic beat here starts off atrial fibrillation. So this is just a nice demonstration of the role that the pulmonary veins seem to play, the key role they seem to play in the etiology of atrial fibrillation. And if you look back at Jimmy Cox's work, the key sort of aspect of the maze procedure has always really been isolating the pulmonary vein. So that has to be the first part of any procedure for AF. But I'm not going to dwell on the intracardiac electrograms. This is just to say how we've approached that over the last few years. Different forms of non-fluoroscopic mapping to try and guide ablation on the endocardial surface, sometimes integrating CT or MR scans. And that can be very useful in guiding ablation. Newer technologies we're dealing with now the ability to perform ablation around the circumference of the vein. So this is a catheter that allows us to ablate not just point to point, but around the circumference of the vein, more of a sort of branding iron, or the cryo balloon, which we're starting to use now, and I've had some good experience. And I think that this is an evolving technology. So both the sort of epicardial approaches you guys are using and the endocardial approaches are developing. However, limitations Manuel's mentioned, I would echo those. The use of the bipolar ablation, which we don't really have, the clamp, is limited by anatomical considerations. And whichever way you use unipolar ablation, whether you do it point-to-point, endocardial as we do, or epicardially, it is difficult to get consistent transmural lesions. These are the ablation modalities, the energy modalities have been used, radiofrequency energy, the one we've used consistently in EP, cryoablation, microwave, high-intensity focused ultrasound, and some approaches with laser. So the problem is if you create an incomplete line, that is pro-arrhythmic. That will encourage arrhythmias because you get slowed conduction and you've set up a reentrant circuit. So incomplete lines are the sort of bane of the ablator in this condition. And I'd say these problems are shared between endocardial and epicardial approaches. Until the FAST study, there have been no real good randomized controlled trials comparing epicardial and endocardial approaches. So I think the FAST study is a really good development, and we certainly need a lot more data comparing some of these different approaches. And I think what the challenge is in the next 10 years or so is to select the right procedure for the right patients to get better results. So Another thing I think is important for cardiac surgeons, because I think this is the change in mindset, that you guys have been used to doing procedures which have a clear mortality benefit. We don't have that data to show clear mortality benefit for AF ablation. And actually, I think because of the patients we're treating, who are the younger, fitter patients, it will be some time before we're able to show a mortality benefit. Because although we may reduce the risk of AF and subsequent strokes, those patients that we're treating are not going to be at risk of that for a few years to come. So what do you need if you've got a procedure that doesn't have this mortality benefit? I think you need a negligible procedural mortality. I think that has to be a first point, first do no harm. And you need clear evidence of symptomatic benefit. So the corollary of that is you should not be treating asymptomatic patients. And I think, let's not kid ourselves, worldwide now, particularly in the United States, there's a lot of patients with asymptomatic AF getting treatment, both from EP guys, cardiologists, and from cardiac surgeons. Personally, I don't think that's justifiable, because we have a procedure which has been shown to provide symptomatic benefit, but not any prognostic benefit. Just really to illustrate where we've come with this, I think we've learned from cardiac surgeons that we really need to get better at presenting our results and our data, and I think you guys have led the way on this. These are just my data from my practice over the last, I became a consultant in 2002, started the AF program in 2003, so since then, 823 procedures for paroxysmal AF. We've got about a 10% redo rate, mostly younger patients, mostly male. And then again, this issue, this just highlights, without going through in too much detail, how you define success is really quite subjective. So subjective improvement, do you feel better? Objective improvement, your results come down. Objective improvement, meaning more than 50% reduction. Subjective cure, have you got any symptoms? An objective cure, when you say you've got no AF over 7 days of monitoring, no drugs, you're down at about 50%. So is it just the placebo effect when you get this improvement? Probably not. Some of the symptoms people get from AF are related to vagal afferent activity. So if you ablate some of the vagal ganglia, you probably make people feel less unwell with their AF. And so there's a biological reason for that. So you may reduce the symptoms, but you do need to be aware of asymptomatic recurrences if you're considering stopping anticoagulation. Complication rates, no deaths. A couple of times I've needed my cardiac surgical colleagues to help me out. Once it's Ben Bridgewater, another time it's Paul Waterworth. Once we perforated the left atrial appendage, and another time one of my fellows put a transeptal sheath into the aortic root. But both times patients ended up okay. So, phrenic nerve injury seems more common with cryoablation. This is a dreaded complication with either approach, epicardial, endocardial. Luckily, we've not seen any. Migraine's interesting, seems to occur after transeptal puncture and then improve, and it has convinced me there's something in this story that closing patent foramen ovale, closing ASDs may be beneficial in patients with migraine, because we see patients who develop recurrence of migraine immediately after transeptal puncture. So this is what I think we all need to start doing. We're starting to get to grips with this in the EP world, is getting more scientific about measuring quality of life data before and after ablation. I think this is very important, because I think our commissioners are going to ask for this. We are now, from a commissioning perspective, being put in the same bracket as hip surgery and knee surgery for osteoarthritis. So this is a symptomatic treatment with no prognostic benefit. So we need to be showing that we're getting some symptomatic benefit. And the two, SF36 is the standard questionnaire used by NICE, a generic one. And what we're recommending in the EP community is people use that, and a disease-specific quality of life assessment, the AF QOL score developed in Canada by Paul Dorian. So I think this is something, if you are getting into this, we do need to all be aware of. Anticoagulation, Manuel's mentioned it. I mean, our standard approach now is to do all AF ablation on therapeutic warfarin with an INR of between 2 and 3. We've found we've had no strokes since we've done that, in over 400 cases since we changed. And we don't really get an excess of bleeding complications. Before, we were messing around with low molecular weight heparin and stuff, and this actually seems better for us. But after the procedure, we have a minimum of 6 weeks, and then we really continue anticoagulation if they've got a long-term indication for it. I guess it's different if you've done something to occlude the left atrial appendage, but we always worry about this risk of asymptomatic AF longer term, which seems to be more common than it was pre-ablation. So we would be pretty reticent, and certainly I wouldn't treat a patient for AF with ablation just on the basis if they want to stop their anticoagulants. It's a common referral, a common request. So lessons we've learned, we've been through this, but another one is it's not always about the pulmonary veins. If you just sort of started treating all your AF patients and not doing any sort of EP study, you'll miss. So this is a focal atrial tachycardia coming from sort of what we would call ligament of Marshall probably area, which is, there's no vein of Marshall to see here, but this is the coronary sinus. And this is one area where you can get a focal atrial tachycardia outside the pulmonary veins. Also can come from left atrial appendage, tricuspid annulus, mitral annulus. So, and also you can get, in younger patients, you can get AV bypass tract. So, you know, it's not always just a pulmonary vein trigger. Mentioned before iatrogenic rhythms caused by incomplete lines. This is a mitral isthmus dependent rhythm, so circulating around the mitral isthmus. After a surgical approach to AF ablation intraoperative, we can cause these as well, just as well. So, you know, I'm not saying it's just surgeons. The problem we can get is if a patient, as Ma'am said, has had a mitral valve repair and then has a ring in and then develops this rhythm, it's pretty much untreatable. You end up putting a pacemaker and ablating the AV node really to palliate these patients. But if they haven't got a ring in, we can often fix these with doing an EP study. So I think this is where if you're going to get good results long term, you need this team approach. There'll be some patients we fail on, we pass on to you, and I would say vice versa. So just moving on towards the end, we've no clear evidence for mortality benefit. I just want to emphasize that, so we shouldn't be doing it in asymptomatic patients. We've certainly found that doing pre-procedure imaging of the left atrium and pulmonary veins can be helpful. Some people are doing this routinely, and certainly you will get some anomalies in pulmonary venous anatomy, which is useful to know in advance. And I would say that, you know, we've sort of learned to develop a structured approach to our assessment of patients, so measuring quality of life before and afterwards, and also look for an objective assessment of their AF burden. Hybrid procedures, just want to speak about these, have been explored. So there's this concept of doing either at the same time or in short succession an endocardial and an epicardial ablation. You've got a better chance of transmural lesions, higher success rates, it would appear, in terms of treating persistent AF. But the Convergent study in the US was stopped early because of 2 deaths. And I think this is an area that will develop, but I think we need to do more work to try and minimize any complications. So my view, I certainly think there's a role for thoracoscopic approach in patients with paroxysmal AF who've had a failed endocardial ablation, and I'd certainly like to have this option. I don't have this option in my centre. I'd like to have an option of a surgeon who is doing these, because, you know, we certainly find that if we're unable to achieve the pulmonary veins the first time, it may be, you know, bad luck, but it's probably something to do with the patient in terms of thickness of the muscle around the pulmonary veins, and I think that a bipolar clamp might have a much better chance of success. I think there may be a role for persistent AF for a hybrid approach, but that's an area that needs further work. And I think for surgeons or cardiologists treating AF, a major challenge will be with achieving commissioning support for this procedure. And I think for all of us doing it, we need to focus on quality of life data. Thank you.